areas that you might want to look to improve. And the idea of this checklist is that there's some evidence, it's based on some research that we can have some confidence in terms of strategies that will work. And Kevin this morning talked about the 6 core strategies, which are really fairly simple. However, as we all probably know, some of the most simplest things are often the most difficult to implement. The issue of conflict across all services is very complex, and for staff working in services, trying to address those issues is also very complex. The other thing about the network is it's quite easy to produce a set of common values and principles and produce a logo and get everybody to sign up and say, yes, we'll be part of the network. That's the easy bit. The harder bit is for those organisations to think about how they can meaningfully impact on practice. So we had this idea of producing this checklist. So I'm just going to give a bit of context, really, and then Colin's going to talk in a bit more detail. Probably everybody's aware of Winterbourne. I'd be very surprised if people in this room didn't watch the documentary, haven't read the subsequent reports that stem from that. And whilst that was quite shocking, I think it kind of gave a misleading focus. Probably many people in this room, like me, are nurses. And there's been a lot of discussion today, probably from a nursing and mental health perspective. And maybe Winterbourne reinforced some of that. But I think the point of the network was actually to bring people together who aren't just nurses, but maybe work in social care, maybe work with older people, maybe work with children. Because the issue of restraint, or the reliance of restraint to manage behaviours that staff find challenging, is not just a mental health and nursing issue. It's a health and social care issue. It's an education issue. And the Panorama documentary that exposed some abusive practices in care homes for older people was just as bad as what we saw in Winterbourne. And as you know, Winterbourne was closed. Those people were found alternative accommodation and services. And I almost felt that it was almost something about the bad place created bad practice. And unfortunately, I've had some brief involvement. There is currently an inquiry happening in Devon where pretty much similar types of abuse that occurred in Winterbourne have happened. And the really sad thing is, unfortunately, some of the people that abuse has happened to previously were at Winterbourne View. So I'm not sure it's necessarily about those individuals somehow drawing staff into abusive practices. So maybe the network's about how do we help organisations to tackle the issues? Because I think for me what's clear is it's more about corrupted cultures beyond anything. I think if the culture's right and if the values of the organisation are right and there's strong leadership, then I think it's harder for abusive practices to flourish. In the absence of all that, I think it's inevitable that abusive practice will flourish. The other thing we have to remember is people are in vulnerable situations, whether it's because they're a child or whether it's because they're an older person with dementia, whether they've got a current ill health problem or a learning disability. That in itself might make that person vulnerable to abusive practices. So I think there's something about our organisations safeguard those individuals and offer some protection. And certainly if I had a family member who went into hospital or care, there's an expectation that they are there, first and foremost, to receive personal care that's right for them. And secondly, to receive that care in a safe way. And I wouldn't expect those paid professionals to do anything to my relative that would compromise their welfare, either physically or psychologically. My expectation of everybody in this audience is you're really skilled people and know how to work with my son or my daughter or my mother or whoever it is in your service. So I think there's something wider. And obviously following Winterbourne, we saw lots of people saying lots of things about restraint. And in some ways, the staff get a raw deal. I don't know anybody that I've ever worked with who skips into work every morning whistling a tune, hoping that before the coffee break they've restrained somebody. That is not my experience. Staff do not want to do it. Unfortunately, over the years, we put so much emphasis on training staff to deal with the crisis. It's inevitable that that's what the staff will do when faced with crisis. And perhaps what we haven't done is enough about preventative interventions and all the other strategies that staff need the awareness and training on. And I think what we can't do is, whether you're a health or social care professional, we can't assume that you're naturally born with the skills. I think we have to recognise is that we have to teach staff the right skills. So where are we now post-Winterbourne? You'll all be very familiar with all these documents, and I think this is a really good move. We're starting to see a connectivity between all this guidance and a focus on how organisations work. So again, the idea was using this as a lever to create a tool that we could make available to members of the network as a reference point really, as a starting point to think about remembering what we do well, because we do lots of things well, lots of times, so we shouldn't beat ourselves with a stick too much, but also recognising that we probably can improve things, and we can, whether that's on an organisational level, or even if I can make a difference and prevent the use of restraint for one individual today when I'm at work, even at that level we can start to make a difference. So Colin's going to talk about how we've developed this tool, and hopefully that will be available to people very shortly when we finish the pilot. So over to yourself, Colin.
Okay, thanks for that, Chris. This is your bit, by the way.
Oh, is it? Yeah.
Do you want to touch on it?
Well, it's just reinforcing what Kevin said this morning, really. It's not just a quick fix, really, and throwing staff on a training event won't necessarily cure the issue.
Okay, as Chris has already trailered, meaning sort of my team, myself, took on this task of trying to answer that question of restraint reduction. Well, what works? What does the evidence tell us that's sort of out there? So we embarked on that. I'm going to whistle through this a bit. I'm very conscious of our chair and our timekeeping. So what we aimed to do was to review the literature which looked at restrictive sort of practice. And as you can see from this, we looked at what was already out there and whether we could highlight any key learning which could be shared from that. And then the second phase of that, if we were able to achieve that, of whether we were then could construct a checklist which allows services to determine the extent to which that was evident in their practice. So it was making that research evidence, if you like, user-friendly for them, that they could access it quite easily and they could check where they were at with or on their own services. This is sort of pretty normal fare for research sort of projects about what search terms we'd use, what we'd include and what we'd exclude, where we would search for this data, and agree this sort of the search strategy. And whatever findings we got, we peer-reviewed those from two separate sources, just to check that they worked out. So certain sort of parameters. These are the settings we looked at, and you can read those for yourselves, but it was fairly broad and encompasses perhaps the work settings of most of our people who are here. We decided to go back to 2004. We thought that going further back than that, then the relevance to contemporary practice became weaker. And we limited our search, if you like, to English-speaking international publications. That's not saying that non-English speaking journals had nothing to say. I think it was just limitation of translation, etc. So what did we find when we did that? Well, the good news is there's actually quite a lot written. Actually, when we went there, there's quite a wide sort of base for us to be able to sort of draw on. And in particular, we found 9 previous literature reviews. And what we did with those was we synthesized them, if you like. It became, if you like, a meta-analysis. So here they've done 9 previous quite detailed reviews, and we actually pulled those together to synthesize. And of course, often within those separate reviews, there was often overlap between them, the sorts of things they were saying. And those of you who've been through the sessions today won't be surprised to see some of the themes that were sort of coming through. Particularly strong leadership was found amongst those, where there was some external review of what's happening, and where after incidents there was a post-incident debriefing. The other thing that was found is that, and again, I think as Chris has already alluded to, we put that 6-stage model, and listening to Kevin's presentation this morning, what the literature tells us is that multimodal, i.e. where there's not just one single entity that's been relied upon to reduce restraint, but multiple ideas. They seem to have the most reliable and significant results. And when we looked at individual diagnostic groups or sort of age groups, we found that certain elements were quite pronounced. For example, here you've got kids services, child and adolescent services, where they found that behavioural and cognitive behavioural programs appeared to be useful. In learning disability, we found these elements about management of maladaptive behaviour, and about changing target behaviour, etc. In mental health, we found these sorts of things relevant. Trauma-informed care, and I was very taken by the presentation we had this morning about post-traumatic events being very important. Changes to the physical characteristics, this whole thing about the environment and what that has to say. And the involvement of service users becoming particularly important. And one of the other big themes coming through was about flexibility and responsiveness. This is about leadership of services. And here, not only responding to the need as it arises, but being flexible about how they responded to that need. A little bit about the red wine example, perhaps, that we've just been given. And overcoming staff barriers and staff resistance, it suggested, is needed for implementation of effective. I think in many of the sort of studies we looked at, this wasn't welcomed with open arms by staff, the idea that they're going to have to change practice or do different things. Often there was a heavy resistance that those implementers had to overcome. And in a sort of summary bit, we looked at 3 particular areas. One, about the organisation as a whole. The second, looking at the multidisciplinary team who were involved in planning and providing care. And then the individual sort of clinicians. And the critical factors we came up with, or the literature came up with these, and again, these are perhaps repeating some of those earlier messages, about leadership, about sharing data, we've heard that many times, we know, about empowering service users, this idea about investment at a number of levels in the organisation, and as I've already said, about resistance. As far as the teams were concerned, this is where this idea of flexibility and responsiveness came in. The idea about service user involvement, about collaborative problem solving, and the idea about teams, ward-based. And at an individual level, the sort of literature started to tell us that importance of about learning de-escalation skills, ideas about teaching service users skills in anger management themselves, assessment for the potential for violence becomes important, and we'll be interested in looking at Roger Almvik's work tomorrow on the Brosset violence checklist. The idea about crisis plans and advanced directives, so there aren't surprises about how we should be responding to people in crisis, about accurate recording and de-escalation in early stages. So we took all that literature and we analysed them to consider how they might contribute to this checklist. That meant we had to do some rewording, so in fact we could use it in an audit type way to make them measurable. And the other thing that we were very aware of, and Chris kindly put them up on the screen before, there's been this plethora of policy documents in the health and social care. In fact, that wasn't a comprehensive list that Chris put in, that was a selection of, I'd have to say. And what we decided was that because services were often expected to conform with policy, that we would produce a checklist for that policy analysis, but we would keep it separate from, if you like, the evidence-based research. And one of the main sort of reasons for that, and this may come as a shock to you, that not all policy is based on research. And in the documents, things would find themselves into policy documents for a whole host of reasons. So we separate those out. So in fact, if you like, there are two checklists, one which actually provides you with a ready reckoner against current policy, but the other one is the evidence-based practice one. We spent the last sort of few months looking at the piloting of that. So when we produced this, we thought it was important to get what we call the usability right. We wanted to test how easy is it to use, to complete and understand. It may mean something to us who've been wrestling with this stuff for a year or more. What does it mean to people out there? And what we basically asked people to do was to work their way through it, to actually use it, go away and use it, and highlight to us anything which they found confusing, unclear, and give us any feedback on if they think additional material or things that they felt were unnecessary. This is a list of the services that we worked with in doing that sort of piloting. Some of them will be with us today, in fact. And we were grateful for them to have sort of done that work for us. And they provided a lot of detail back. These are a mixture of high secure services, NHS trusts, as well as independent sector providers. We also asked members of the Restraint Reduction Network. You may know that there's a whole group of people involved with that, and we sent it out to them as being experts in their own areas, asking them if they could provide feedback as well. Just a technicality of it, we asked people to complete this online, so we've actually got the checklist as an online document. So rather than and what we've been aware of is often when you amend documents, there's multiple versions flying around, and the way of keeping control of that was to do it as an online activity. So that's the way we actually handled it. Based on all that feedback I've mentioned, we've made amendments in preparation for implementation. And that's about the stage we're at the moment. So it's been through that sort of process. And we've thought long and hard about what we think the checklist is and how it might be used in practice. Now our view is really that this is really a practice development document. We're not putting it out there as a research document or something in which services will be benchmarked against, because I'm aware one of the feedbacks we got of people quite anxious about, if I get a bad result on this, is CQC going to pick this up and use it against me or whatever of that? And we didn't want to go down that road. So it was really to provide services as a way of them checking how they were performing as a self-analysis, if you like, rather than in any other way. And we're aware we could use it at a number of levels. So some people who completed it from an organisational level. So they thought about the trust when they filled it in. So they talked about policies and procedures and training and lots of other things. Other people completed it at a much, if you like, lower level, closer to the client in services. So we had ward managers who completed it. And so they gave their perspective from that. And we're aware that the tool is usable at a number of levels within the organisation. Thoughts we have about it, I say, services could use it just as a self-assessment, or they could use an external sort of group to do it. So if they feel that they're going to get not polluted by the completion of it, they could partner up with another service or another ward and ask them to come in and actually provide that external view of the way they're actually performing. What we think it's most useful for is actually in developing an action plan, which can focus on any areas identified as requiring improvement, or they could concentrate on particular topics. And talking to the people who complete the pilots, it is quite a detailed document. I think it would be ambitious to think that you could tackle everything that you'd marked yourself as requiring improvement on. So some services have thought, well, we could go for what could be called low-hanging fruit. We'll go for the stuff which we think we can achieve quite quickly and quite easily. It's not going to take a lot of resources. Others might be interested in tackling specific areas, such as service user involvement or whatever their sort of choice. So this idea of an action plan that they could complete, dependent upon where they see their priorities, which they can then revisit however further down the line they want to, 6 months, 12 months, just to consider how far they've travelled on that journey. And organisations themselves may wish to, if they've produced an action plan, think about, well, how can we evidence and demonstrate improvements on this? So they may be thinking about, even before they embark on implementation of the plan, well, how are we going to measure this? So I don't know, if it's service user involvement, well, how will I know that we're doing that better in 6 months' time than we're currently doing? So giving some thought about how that might be legitimately remeasured. And what we are going to do is, as we get this as a tool and made available to the network, asking people now about a more wider use of the checklist, for them to share their own experience with us and ideas about how it might be further refined and developed going forward. And if you haven't already got that website, or if you're not currently a member of the network, this is going to be your way of accessing the checklist. We wanted to make something available which we felt was of practical utility and value to the Restraint Reduction Network, and this is one of the first products which we're going to be putting up there and being made available for you. But we're happy to answer questions on that.